Hotbed Talk.
My name's Daniel Conway. I'm a consultant in anaesthesia, critical care, and I'm the group lead for perioperative medicine at Manchester Royal Infirmary. And I'd like to wish you a warm welcome from Manchester and point out I have no commercial interest to declare, but I am the chair of the Manchester Perioperative Medicine Society, and I'm also the course lead in a master's programme in perioperative medicine at Manchester Metropolitan University. And today I'm going to talk about the role of functional assessment and status in perioperative care, and point out to you that functional status is really about a person's ability to get about their normal daily tasks and their capacity to do so, and that includes both mental capacity and physical capacity. And we've heard a lot about fitness in terms of endurance already, and we know about strength as well, but there are other elements to functional status that are also really important. And really, perhaps assessing functional performance is something that we've overlooked in medicine, although it's commonly done by therapists and in other specialties. And so what I want to really talk about is how functional performance, which is where there's this combination of capacity, mental health and cognitive abilities, a person's social, environmental support, and the burden of concurrent disease, can then lead to hopefully changes and improvements in perioperative outcome and help us understand what perioperative outcomes patients can expect. Now, in the next talk, I think you're going to hear a lot about frailty, which is an age-related functional decline. So I'm not going to talk about that. And I understand and I know that for many of you are very passionate about the perioperative care of people with learning disabilities. However, for the purpose of this talk, I feel that that's an entire topic in itself. And indeed, we're going to have a whole chapter on people with learning disabilities in our master's course. I'm not going to be able to talk about that today, but I do recognise it's important. So on a more general theme, when you look at the activity that people say they do and how that impacts upon their long-term mortality, there is some really strong evidence. This is from nearly 1 million patients in 22 longitudinal cohort studies that shows that the activity that people say that they do will impact on their risk of death. And in the graph, you can see that anything really below 20 MET hours per week is associated with an almost exponential increase in the risk of death. And this is where the WHO and others have come up with this idea that a moderate amount of exercise 5 times a week for 30 minutes, which is the equivalent of about 11 or 12 MET hours per week, is the recommended minimum activity that people should be doing. If you look more specifically at cancers and I want you to remember that surgery remains the mainstay of treatment for most solid organ tumours. And again, from a similar kind of cohort studies looking at self-reported activity, when these researchers took the patients who reported the lowest amount of activity, the lowest decile of self-reported activity, and compared it to those who reported the highest decile of activity, and then looked at their subsequent development of cancer based on cancer registry entries, they found that a lack of activity was probably the biggest risk factor for the development of cancer, greater even than smoking for almost all cancers apart from lung cancer. So we can see that activity most definitely impacts upon health, and crucially, those patients who perform less activity are probably more likely to present to us for surgery. And so how do we go about assessing functional status? Well, I'm not going to sit here and pretend that I'm an expert, because as doctors, it's something that we touch upon, but we don't spend our lives doing it. But in fact, we're very lucky that as part of our multidisciplinary team, we have occupational therapists and physiotherapists like Liz here in the picture who do this all the time. And the very basic activities of daily living as outlined here, there's 6 including eating and bathing, dressing, etc., are assessed almost on a daily basis by therapists all over the world. And even more complex ADLs, such as medicine and finance management, and whether people can go shopping, even do their gardening, are assessed routinely by our therapy colleagues. Now, fortunately, there are some standardized tools that are available that have been validated in numerous populations that allow us to understand a little bit more about a patient's functional status. I'm sure many of you will have heard of some of these, including the Bartel Index, which is 10 items of ADLs, which are then totted up and scored out of 100. There are other more complex tools such as the IADL, and then some of you may have heard of the DASI score, the Duke Activity Status Index, which I'll talk about a little bit more because that's being used in perioperative practice. And then there are more complex ways to assess a person's functional status, such as really having your therapist observe a person either in a clinic situation or in their own home. We use tests like timed up and go tests, as well as using actigraphy trackers. So there are a number of ways to assess functional status. And I'm going to talk a little bit more about how these assessments tally and can affect perioperative outcome. Now, of course, there are a number of pitfalls with some of these self-reported tools. Most frequently, patients probably exaggerate what they do, and so a number of studies using different self-reported tools consistently show in different populations, including cancer survivors in this Spanish study, that patients overestimate their activity, and it appears that it's older, less fit men who often exaggerate their physical activity and perhaps their golf handicaps as well. But even the original DASI studies, when trained researchers were interviewing patients, they got much more consistent and validated scores than when patients just self-reported on a piece of paper. So where does this take us into functional assessment in perioperative care? Well, I think obviously we're really talking about fitness for surgery, but also trying to understand what the risk is for each individual patient. And not only that, but if we're going to be putting prehabilitation programs in place, really they should be targeted to the specific needs of those individuals. And so understanding more about what their functional status is can help us tailor that prehabilitation to the needs of the patient. Not only that, but it's quite important that once a patient's had surgery, it's an idea to predict their rehabilitation needs so that we can give people an accurate and fair estimation of what's going to be happening to them after their surgery. And all this ties into shared decision making. And don't forget that for a lot of surgery that we do, and I've talked about cancer surgery, but for a lot of other surgery we do, for orthopedic surgery, for example, the patients are presenting for surgery because they hope to see an improvement in their functional status. And so it makes some sense if we actually knew what that functional status was before we embarked upon that surgery. So it is important. So I want to just focus on a couple of studies that have been done in the perioperative arena. The MET study was published quite recently, and a follow-up was published in the BJA. And this was a big study, 1,400 patients of patients over 40 years old with one or more comorbidities. Now, patients were excluded if they were already due to have a CPET test. So arguably, some of the higher risk patients were taken out of this study. However, they all had functional capacity assessment done by one of us, by an anaesthetist, where the anaesthetist kind of estimated the METs and their activity levels, either poor, moderate, or good. A bunch of demographics, revised cardiac risk index, and also the DASI questionnaire was completed by the patients, who also then had a CPET test and a serum BNP taken. Just to remind you that what the DASI test involves, so you can see it's these 12 questions, and it's the answer is yes, can you do something? And the answer is yes or no. So can you run a short distance? Question 5 gets 8 points. If you say yes, 0 if you get no. And so in the MET study, the median DASI out of a maximum score of 58.2 was 42.7. So obviously these were reasonably fit patients. But with a range, with a decent range in that DASI questionnaire. And in the MET study, not a very high number of patients developed serious complications, or the primary outcome, which was death or myocardial infarction at 30 days. However, the subjective assessment by the anaesthetist was unable to discriminate in the primary outcome, nor was VO2 peak, although it was associated with the secondary outcome of postoperative complications, nor was anaerobic threshold, but DASI was associated with the primary outcome. And the subsequent study that I mentioned that came out earlier this year in the BJA suggests that the cutoff for DASI is around 34. So you remember the median was 42, but the cutoff is lower than that, it's 34. And NT-proBNP also is associated with the primary outcome as well, with a cutoff of 300. So there's definitely something to be said for using these questionnaires, and in particular using the DASI. Now, I want to focus and change focus a little bit and talk about cognitive function. Now, there are 6 key domains of cognitive function. So as you can see, looking through these different domains, the way our brain works is highly complex, and so it's quite difficult to properly assess cognitive function. And again, it's something that probably should be done by an expert, by a neuropsychologist, for example. However, there are simple screening tools that are used every day in hospitals and in preoperative assessment clinics that allow us to give us a feel of somebody's cognitive function. So there's mini-mental state, there's a Montreal cognitive assessment, and there's a very simple one called mini-cog as well, which is really only 2 questions, drawing a clock face and recalling 3 words. However, as I've said, there are neuropsychological tools which take a long time and need to be done face-to-face with a professional, which are much more in-depth. Thinking about cognitive function, well, firstly, is it possible to use these in pre-op assessment? Well, here's a little study that we did just as proof of concept that we could use the MOCA both in a preoperative assessment clinic and then again on a post-anaesthesia care unit. And what we found was, yes, patients were able to perform the MOCA test, and also, if you look, about a quarter of our patients, these were all over 65, had some deficit in the MOCA in that they were less than 26 on the score. A similar study was done by Cully and colleagues in Boston, and these were orthopaedic patients, over 200 patients, 65 and over, but not known to have any cognitive dysfunction. And they were screened using the mini-cog, which, as I've said, is probably the simplest tool that we can use. But they also looked at METs in the form of DASI. They looked at demographic data, functional status in other forms, and then looked at some post-operative outcomes in these patients following their orthopaedic surgery, such as did they have to go to rehab or intermediate care before they got home? Did they develop any delirium or other in-hospital complications, and what was their length of stay? And what Cully and colleagues found in Boston was that, firstly, about 25%, a quarter of their patients, had some elements of mild to moderate cognitive impairment when screened. So it's not a diagnosis, but it's a screening tool that suggests some cognitive impairment. And of those who had cognitive impairment, they were much more likely to be discharged to a place within the home, either to rehab, etc. They were more likely to develop delirium, and they had a longer hospital length of stay. And if you look at where I've highlighted the results table here, you can see that in the multivariate analysis, when all the other factors had been taken into control, taken care of, that both mini-cog and the METs, as measured by DASI, remained significant in terms of predicting poor outcomes for patients, whether it was delirium or, as you can see on these slides, discharge to rehab or extended hospital length of stay. And a personal communication to me from one of the authors is that when they were talking to these patients, the researcher discovered that 10% of the patients who had already given their informed consent to have the surgery could not describe what that surgery was, which is worrying as well, which is why it's probably quite important for us to think about cognitive state before we embark upon major surgery on patients. And if you think, well, it's orthopedics, so here's a similar study from cancer surgery patients, and again, they looked at functional status in terms of the timed up and go test, the Bartel index, and the mini-mental state examination of cognition, and then followed those patients up a year after their cancer surgery. And what they found was that those patients who had a combination of relative dependency based on the timed up and go test and the Bartel index, or had a reduction in cognition as measured by mini-mental state, this was highly associated with mortality using multiple regression at 1 year. So there's no doubt that functional status, cognitive function, can be used to predict outcomes following surgery, whether that's cancer surgery or orthopedic surgery. So what use is that to us? Well, I think that we should probably be thinking more about shared decision making and where we use functional status in terms of shared decision making. And I think that for a lot of these type of orthopedic surgery, for example, that shared decision making alongside a multidisciplinary team with the surgeon and with a therapist is really helpful, because what you'll be able to do is to talk to a person about what their functional state is and how likely that is to be either improved or made worse by surgery. And of course, that will then facilitate informed consent, because often functional status is part of the goals of care. And this editorial, I think, or study, in the New England Journal, has already outlined that for a lot of patients who are seriously ill would not undergo heroic treatment if they knew the likely outcome was survival, but with significant functional or cognitive limitations. So we really need to know the baseline so that we can engage patients with what their likely outcomes are. So I just want to talk a little bit about other potential uses for functional state assessments. And this is something where I don't think there's such strong evidence yet, but it's something that probably is part of good practice and we're doing to an extent anyway. Firstly, we can use functional status to identify patients at risk of complications and hopefully then modify those. So a person with cognitive impairment, we would be very careful about giving long-term benzodiazepines to or long-acting opioids to, because this is likely to cause increased delirium and delayed discharge, for example. So I think most people are doing this already. I think understanding a person's functional status and the home scenario is really, really important, so that when patients have their surgery, we can already anticipate what needs they're going to have, whether it's to go to rehabilitation or intermediate care, or whether they need modifications to their home or more support at home. And we do that in advance rather than it be a great big surprise to everybody after they've had the surgery that they can't just go straight home because they've got all these requirements. And therefore, simple functional assessment can then allow a prompt referral to allied health professionals and also community organisations as well. And so just to conclude, I would suggest to you that functional status is really integral to perioperative care, particularly for higher risk patients, in order to support risk stratification and give patients a better understanding, a more granular understanding of their risk. And that will then allow them and their families and the healthcare professionals looking after them to engage in shared decision making that will hopefully allow for proper informed consent and patients getting the outcomes that they feel is right for them. I think it's reasonable to say that for a lot of surgery, functional status should actually be a goal of care and therefore an outcome measure. And certainly in the UK, the patient-reported outcome measures, so-called PROMs, have been used in the past, and I think there's going to be plenty of focus on those in the future in terms of measuring the success of perioperative care. I would suggest to you that a multidisciplinary approach in the perioperative period is really important in terms of understanding that functional state, because actually the surgeons and the anaesthetists are probably not the experts in measuring these or even helping to optimise these either, and we've got to rely on our therapy colleagues and pharmacists to support this. And finally, as I said earlier, we're going to hear a little bit in a moment about frailty, and I'd like to point out that there are other groups, people with learning disabilities, who have quite specific limitations in their functional status, who require special attention and additional support from our multidisciplinary teams. And so finally, thank you all for tuning in. I'd like to point out that we have some resources that are free for any of you to use, including some videos on YouTube. If you go into the search bar on YouTube and put ICOF UK, we've got some perioperative tools that you might find helpful that you can let your patients have a look at, gives them an idea what they might happen to them when they have their surgery. And so I just thank you very much for listening, and I'll see you shortly.
Top Bed Talk. Thanks for listening to Top Med Talk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to Top Med Talk and EBPOM at ebpom.org.